Dr. Shahul, you can take over.
Uh, Assalamu alaikum. Good evening. I welcome you all to today's webinar session hosted by Global Dental Professional GDP Group. And our guest for tonight will be Dr. Sufiyan. Before we start, I am Dr. Shahul, the host and moderator for today, prosthodontist by profession. And my fellow colleague, Dr. Sufiyan, also a prosthodontist, will be taking on. But before that, a short introduction to our presentation. So if you see, most of the time as clinical dentists, not as specialists, but as general dentists, it's the type of dentition which is undesirable, and that is what we see on a day-to-day basis. So as dentists, our what we need to do is to restore these type of dentitions. So what are we basically trying to do here? We are trying to add functionality along with deliver aesthetics. But in this process of adding functionality and delivering them, we are using multiple tools to rehabilitate the oral cavity. We are using dental crowns, using dentures, we are doing fillings, we are using implants. But at the end of the day, we are trying to replace the unrestorable tooth or teeth to the oral dentition. When you talk about restorations, we have both internal restorations, which are basically your amalgams and composites, and we have external restorations, the most common being zirconia is very common today, the porcelain fused to metal, the full metal crowns. Whether the crowns or these bridges are made upon, are being going to be cemented on natural teeth, or they're going to be cemented or going to screwed upon dental implants, irrespective of that. Or whether we are using dentures, whatever the thing may be, the biggest nightmare or the headache for the dentist would be occlusal high points and associated dysfunction related to it. The problem here is where to adjust, how to adjust, and how much to adjust. And this is something which is never taught to us. We take our articulating papers, we hit them, we put them onto the processes, and then we see multiple points, and that is where we get stuck. So today, Dr. Sufiyan will be talking about the art of selective grinding, a topic which is given very least importance because of various factors. Most importantly, the operator being unaware of what to do and when to do and how to do. So Dr. Sufiyan will be putting some light on it. But before that, I would like to introduce Dr. Sufiyan to the group. He's done his BDS from JSS Mysore in 2010, his MDS from NDCH Raichur in 2015. He's also done his membership in dentistry from the Royal College of Ireland in 2021. He's a fellow and master of ICOI from 2022 and a master of GCOI in 2024. He's a key mentor and speaker at various national and international podiums, and most of his time he is busy in writing articles for us so that we can go and search him out. Right now, he's currently practicing in Kuwait as a chief prosthodontist and implantologist, and he takes his implant practice very seriously. And most importantly, he's going to be spending a lot of time today giving us a highlight about how we correct this most common thing called as high points. So off to you, Dr. Sufyan. Thank you.
Assalamu alaikum, everyone. Thank you for that nice introduction and telling us about what will be a webinar is all about. And Dr. Shalu is there with me, who is a co-host and will be handling the session. I'm happy to share my webinar with him as well. He's a equally eminent prosthodontist, and he'll surely guide me and add the points which have been left. Okay, so let's get directly into the webinar. So I'll share the screen now. Yes. Can you see the screen?
Yeah, we are able to see the screen. Thank you, Dr. Sufiyan.
Can you see the screen, the title slide?
Yes, sir, we can see your screen.
Yeah. And also, am I audible enough? Can you just
Yes,
give
sir,
me a
you're
thumbs
audible.
up if in the chat here? Yes. Yeah. So, Assalamu alaikum, everyone. It's been a long time since I saw you all in the GDP. Hope you are all doing well. And first of all, I would like to congratulate the GDP team at the platform for their outstanding work in sharing knowledge and empowering all us across the globe, in fact. So, the commitment to education through the initiatives and YouTube, especially, and these kind of webinars which will help us, general dentists and the specialists, is a really commendable job. So I'm grateful that I have been given this opportunity to contribute and present this webinar. So thank you once again for inviting me. So imagine this situation. 2 days back, you have cemented a crown. You made sure there is no excess cement, all clean. You checked the occlusion, everything is fine. Patient is happy, paid the charges, remaining charges, whatever the patient had to pay. Patient walks out into from the clinic happily. And today is Saturday. Today night, you have around 11:30. You receive a call from the same patient saying that he or she is not comfortable with the new crown and has headache or jaw pain while chewing. Does it happen to you any night? Yes. If yes, just give me a thumbs up in the chat, or if you are faced yes or no in this kind of scenario. So we all understand the significance of this occlusion in achieving this kind of a successful restoration. We all think that the restoration is fine, there is no cement, and the patient walks out happily. But the nightmare what we have after this, getting a call from this kind of a patient, and that's what we are here for, to learn about how to tackle this situation. So through this small talk of mine here in this webinar, let's travel on this journey to achieve and know how to achieve this optimum occlusion in crown and bridge prosthodontics, right? So as I said, I look every treatment as a journey, and in indirect restorations, these are the steps we follow: the treatment planning, tooth preparation, impressions, temporization, material selection, cementation, occlusal adjustment. So every step is equally important to achieve this successful outcome. Cementation appointment will be a special one. You know why? Patient has come for this kind of restoration, and patient is happy that and also thinking that this today will be my last appointment, and I'll get my crown or a bridge or a prosthesis ready. And we as a dentist also will be happy. Why? The payment will be done, the financials will be covered on this appointment, right? So this, as I said, imagine now, and the patient has finished the payment, walked out from the clinic very happily. Next day or 2 days back, 2 days later, you receive a call saying that you're not happy with the crown. Dr. Saab, I'm not happy with the crown which you have placed. Before it was much better, and now it's getting worse day by day. So what might be wrong? So let's get to know in this webinar all these aspects of covering. Okay. So one more important, what leads to all these issues is the occlusion adjustments, right? So this journey is going to be a little difficult one. So I'll try to make it as easy and simple as possible, right? So occlusion, if I can say, you'll call the patient, check with the articulating paper marks. You find this mark on the crown. What do? You quickly grab high-speed handpiece, take a burr and chop off all the markings on that crown. Why? You are in a perspective thinking that the patient doesn't create any issue, or you'll be thinking that patient might lose the patient, and patient might think wrong about my treatment which I have given. So take out all the marks, patient will be happy and he will not complain about any issue, right? But what are the implications of doing this? So let me systematically break it down for you all. That's about high points, and we will overcome this nightmare of ours after we get to know what are the points to be taken care of. So before jumping directly into the high points, let me discuss with you a little bit about occlusion. So I would suggest you all to grab a pen and paper. Why? Because I'll be introducing you to a few of the terminologies and repeating them in the course of my presentation. So whenever I repeat them, you can quickly go back and refer to that point which you have written, right? All right. So what is occlusion? So to start with, if I can say in the simple terms, occlusion is nothing but contact between the maxillary and mandibular jaw when all the teeth are in contact with each other. Okay, so if I can split this occlusion in 3 types, I can do that in occlusion, which is ideal, functional occlusion, and pathologic occlusion. So these are the 3 kinds of occlusion. So let's get to know this ideal occlusion. Ideal occlusion is when the maxillary teeth slightly overlap the mandibular teeth on the labial surface, and in the teeth in the maxillary arch are in maximum contact with the mandibular teeth in a definite pattern. What is this definite pattern? We all know ideal occlusion, the mesiobuccal cusp of the upper first molar is coinciding with the mesiobuccal groove of the first molar in the mandibular arch, right? So this is the ideal occlusion. Can we achieve this? Yes, that's what we are aiming at in a quadrant rehabilitation, or in a full mouth rehabilitation. This is what we will be aiming at. So next, I'm interested is in the functional occlusion. So if I can tell you in a simple way, functional occlusion is nothing but occlusal contacts of the maxillary and mandibular teeth during function. So which are these functions? First one is a speech, during chewing, that is mastication, and the third is a swallowing. So these are the 3 areas where the functional occlusion comes into play. So let's get into detail of this functional occlusion. So when I speak of this functional occlusion, there are 2 separate entities in this kind of occlusion. Which are those? The first one is static, and the second one is dynamic occlusion, right? First one is a static, and second one is the dynamic occlusion. So when I speak of the static occlusion, it should come to your mind that this kind of occlusion, maximum teeth contact will be there. That is nothing but the term you might have come across before, maximum intercuspation. So all maximum number of teeth will be in contact with each other. That's a stable position for that kind of a patient. Okay, maybe the patient is having ideal occlusion, or patient is having a crowding or a crossbite. Whatever the kind of occlusion the patient is having, that's a maximum intercuspation. That's the ideal, that's a stable position for that particular patient. Okay, that is simply known as MIP. That is maximum intercuspation position, right? So how should static occlusion in posterior teeth be? Static occlusion is nothing but open and close. So when the patient is opening and closing, what are the kind of occlusion and what are the kind of occlusal marks you get when you check with the articulating paper, right? So this is the ideal occlusal points in the anterior and in the posterior. Okay, so let's concentrate on the posterior. So you see these occlusal points here. These are the ideal occlusal points in the mandibular and in the maxillary posterior teeth. So which is a functional cusp in the maxillary? That is the palatal cusp, right? So one occlusal point in the premolars in the palatal cusp, two occlusal points in the two of the cusps in the molar region. So these are the ideal occlusal points, and one in the mesial marginal ridge of the premolar and the molars, and other one in the central fossa. So these are the ideal occlusal points in the maxillary. In the mandibular, which is a functional cusp, the buccal cusps are the functional cusps. So buccal cusps are marked, and unlike in the upper, the lower will have markings on the distal marginal ridge and in the central fossa. How do you remember this? Maxillary is placed forward. That means the point will be in the mesial marginal ridge. Mandibular is placed backward. And remember, as it, the marking is there in the distal of the distal side, that is the distal marginal ridge, and the central fossa in molars. So these are the ideal occlusal marks. So I am aiming at this 4 marks in the molars and 2 marks in the premolars, or at least 3 in the molars and 1 in the premolar. And you can additionally have 1 occlusal mark in the central fossa of the premolar as well, right? So now that's about the posterior occlusal point. So how should static occlusal points in the anterior teeth be? Okay, not just the posteriors, the maximum intercuspation in the anterior also. So after giving a crown or a bridge, you will first take articulating paper and ask the patient to bite. That is, you are recording the static occlusal points. So you should have this kind of occlusal points, right? And the anterior. Mesial marginal ridges of the centrals. Mesial are the distal marginal ridge in the lateral, and in the canine groove, right? That's in the anterior. That's about the static occlusal points in the anterior and the posterior. So now let's see how the dynamic occlusal points will be. So which are these dynamic occlusal points? I mean, what is the dynamic occlusion? It's nothing but protrusive movements or the lateral movements. So the occlusal marks in this kind of movements are the dynamic occlusion points. So when the mandible is got forward and lateral excursions, you should have this kind of dynamic occlusal points. Anteriors will have the lines like this, and the posteriors in the like this in the lateral excursion marks. Okay, the points you see are the one in the blue are the static occlusal points, and the dynamic occlusal points will have lines, right? So when the mandible is got forward and in the lateral excursions, you should have this kind of dynamic occlusal points, as I said. So there should be line traversed from that static occlusal points away from the static occlusal points in the anterior. At least you should have 1, 2, 3, 4, 5, 6 as the ideal static occlusal points in the anterior. So when we are concentrating on this, when we are replacing the anterior bridges in the anterior dentation, okay, missing anteriors, or you are giving a canine to canine bridge, this kind, or you are doing a full mouth rehabilitation case. Okay, so 6 occlusal points are ideal in the anterior. Okay, so if you don't get 6, at least 4 is near to ideal, or at least 2 occlusal points in the anterior when the mandible is in the protrusion is acceptable, but not 1. 1 maxillary incisor guides the whole of the mandible is not acceptable. Such tooth is overloaded, and within the span of time, the consequences has to be will be seen in this tooth. That is mobility, migration, attrition, or it might fracture, or it will go for extraction. So anytime you replace the anterior or the posterior, make sure the anterior guidance is always there in the patient and it is not overloaded. So it means that the occlusal point should be uniform in all the anterior teeth. Okay, how do you check that? You place articulating paper marks and ask the patient to move the mandible in the forward. Brush the labial surface of the mandibular incisors in the palatal surface of the maxillary incisors. That's how you check. Right? The two main patterns of the lateral exclusive movements are right side and the left side. So when you check this, there are two schemes of occlusion which can be seen in the lateral exclusive movements. Which are those? Group function occlusion and the canine guided occlusion, right? So let's see in detail about this. So what is group function occlusion? So making contact with more than one tooth when you move your jaw in the sideways. Okay, so now you will do this exercise. Bite and try to brush the canines and move your mandible to the right side. Right? When you do this, if your canine, premolar, and molars are touching, the cusps are touching with each other, that is nothing but group function occlusion. So you are having a group function occlusion, right? So if you keep articulating paper in between the jaws and try to move your mandible on the right side, okay, that becomes your working side, and you will see the drag marks like this, okay? So when you have multiple markings like this in the posterior with the canine, starting the canine, you are having a group function kind of occlusion. So if you're moving on the right side, this becomes a working side, and the other side will become a non-working side. So vice versa, when you are moving the mandible in the left side will become a working side, and the other side will become a non-working side. So always the working side marking should be there. Okay. When you have marking on the non-working side, these are the occlusal interferences you will remove, right? So that's the importance of checking the articulating paper marks in the lateral excursions. So advantages of having this group function is, so imagine your multiple teeth are touching with each other, so the force loaded is equalized. Okay, there will be distribution of forces during the chewing or in the lateral movements. Okay, when do you give this kind of occlusion? When the periodontally compromised teeth are there, or you are giving a quadrant bridge or a quadrant dentistry, you are following, you are rehabilitating the quadrant, you give this kind of occlusion, or you're giving a full mouth rehabilitation for a case where the periodontally compromised teeth are there, you can give this kind of a occlusion. Okay, so next one is a canine guided occlusion. So what is canine guided? So you can do the exercise now, bite and try to move with canine as the reference, get the mandible to the right side and stop at the point where the canine touches to pointed, canine cusp to cusp in the maxillary and mandibular, and see if you have having a gap in between the teeth in the posterior. If you're having a gap, you are having a canine guided occlusion. And if you imagine you are having a molar touching and premolars not touching, that is the point where the occlusal interferences are there. Then that might, for you, it's an intercuspation, maximum intercuspation, and you will have an equilibrium. But over a period of time, only that tooth is in contact when the canine is coming in the right side. Okay, the molar cusp is touching. So that is the point where the attrition will happen. Okay, so if you're having a canine guidance, if you're rehabilitating a patient with a canine guidance, the maxillary and mandibular cusp of the canine should be touching, not all the teeth. Okay, there should be gap in between all the posterior. That is about the canine guided, right? So the canine is guiding whole of the mandibular jaw. Only one tooth is guiding whole of the mandibular jaw, right? So you might be wondering how come a single tooth is guiding whole of the mandibular, and why is it so important to get a canine guided occlusion, right? So remember our BDS days, we had studied in our dental anatomy that canine has the longest root. So longest root, it means the crown root ratio is more, right? The root ratio is more when compared to the crown. So it means that the root is covered with dense cortical bone or has a good support, and longer the root, which means the PDL is more, periodontal ligament is more. If PDL is more, we have more mechanoreceptors. So mechanoreceptors are nothing but these are the small receptors in the PDL which will guide the movement of the mandible and the teeth as well, right? So, and is also placed in the arch in such a way that is not so near or so far from the TMJ and the muscles. That's a cornerstone which we have studied. So that's the reason we are very concerned about getting a canine guided occlusion so that it will disocclude all of the posterior teeth here, taking up the load, right? So when you check with the articulating paper mark in the right side, that is a working side, only canine will have this kind of a mark line, unlike in the group function where you have all the marks. Okay, there should be no markings in the posterior, only marking in the canine. If you have marking in the posterior, one or two markings, not uniform marking, then these are the occlusal interferences. The same thing you will be checking in the other side, taking the mandible on the other side, right? So articulating papers, with this is what we'll be checking the occlusion with. So now you know the different types of occlusal schemes. Let's see how to record these occlusal points, right? So which are the articulating papers to be used? These are the different types of articulating papers. Articulating papers, 80 microns, 40 microns, 65, 12 microns, 100 microns, 8 microns, 200 microns also is there. Okay, so these are the kind of articulating, different types of articulating papers, and this is articulating paper holder, and this is a U-shape articulating paper holder. It comes with strips, it comes with a roll, foils, right? So which articulating paper to be used? If I can tell you based on the thickness, there are 100 microns, 200 microns, which can be used for removable prosthesis, the thicker ones. The medium one, that is 40, 20, or up to 65 also, or 80 also can be used in crown or bridge. And the thinner ones, that is 8, 10, 12, 20 microns can be used in implant prosthesis. Okay, so what is the difference between this thin and thick articulating papers, right? So usually the thinner the articulating paper, the more precise the marks will be. Okay, so that will generate less uniform and larger area of the occlusal paper points. Okay, the thinner and if you're using a thicker one, it will give a broader occlusal area. Okay, right? So that is the difference between the thicker and the thin articulating papers. So I am fine with getting a larger area. I am not fine with having a occlusal point where it is concentrating all the occlusion in that particular point. Okay, I'm not happy with that. So I'll try to get a occlusal area, but at the same time, I'll also try to get a area which has a very minimum and healthy occlusal marking. Okay, not overloaded in one particular area, right? So that's the difference between the thicker articulating paper and the thinner articulating paper, right? So when to check the occlusion? We all check the occlusion after cementation of the crown or a bridge or a prosthesis, right? No, that's not right. We have to check the occlusion even before the start of the procedure. So what do? You have to check the existing occlusal scheme of the patient. That is, you take a U-shape articulating paper, and check the occlusal points in the patient, what the patient is having, right? You take a photograph of it. You take a photograph of it, and then you will record it and you will document it and keep it aside as a reference. Why? Because this is the same kind of occlusion you will be giving back to the patient after the prosthesis is delivered. And also you will share this photograph with the lab technician and tell him, Mr. Lab Technician, if you're doing a single crown or a bridge, get these ideal occlusal points which the patient is having, and also keep the same occlusal points what the patient is having in the other natural teeth. Okay, you're not supposed to change the existing occlusion of the patient unless needed. When it is needed, it is in the full mouth rehabilitation cases or in the quadrant rehabilitations. Only then you are changing the occlusal scheme of the patient. If not, return back the patient's maximum intercuspation, right? MIP, what I told you about. right? So share this photograph pre-op with a lab technician and tell him to replicate the same. And how do you check? How do you check the static occlusion? Dry thoroughly, 3-way syringe, take articulating papers, and ask the patient to open and close 2 or 3 times. That is open, close, tap, tap, tap. And then you will see this kind of occlusal paper marks. So there are so many occlusal papers, as you saw in the previous slide, the different thicknesses and colors. How I use? Let me introduce you to this technique which I use, that is called 2C and 2T technique. What is this 2C and 2T? Two different colors, that is blue and red, I used with 2 different thicknesses. So it means imagine now I'll be using this for a static occlusion. I'll be using 2 colors, okay, and 2 different thicknesses. So 2 colors, blue one, I'll use a thicker articulating paper, and a red one, a thinner articulating paper. With this technique, I can get a occlusal area with a blue articulating paper, and I'm concising the occlusal point and reducing it with a thinner articulating paper, that is 8, 12, 20 microns. Okay, and also please use a good quality articulating paper from a good company. Bausch is what I have been using, and Dentsply is what I've been using. There are many articulating paper marks. Dipti articulating paper is not a standard articulating paper. Carbon paper is not a standard articulating paper, because even though the patient doesn't bite, you just brush it over the tooth, you will have the markings, right? So this will give a false marking to us. Henry Sheen is also a good company. So before you go ahead, just read their manual, the paper which is attached along with that box. What is the thickness of the articulating paper? Okay, so use a thicker one, different color, and a thinner one, different color. Okay, let me tell you how to use it. So now you have used this after the crown cementation. You have checked this articulating paper mark, the blue one with a thicker, and the red one with the thinner articulating paper. Okay, let's dissect this occlusal paper marking. We'll have a broader area, that is a blue area. You will have a red area, that is a thinner articulating paper marking, and you'll have this unmarked area. Okay, so as I said, blue articulating paper, I'm repeating again and again so that you will get used to this. Blue area with a thicker articulating paper, red one with a thinner articulating paper. And in this one, which is the high point here, which is occlusal interference, blue one or a red one? Your occlusal marking is, your occlusal high point or interference is this unmarked area. You know why? This unmarked area is confined within the larger occlusal area, and there is no marking here. Why? Because the occlusal point is the occlusal load is such that the tooth to tooth contact is there, and the tooth has penetrated through the articulating paper, and that's the reason why there is no marking here. You get the point? Even though you reduce this and keep this one, you still have kept the occlusal interference there. So your first goal should be to eliminate this unmarked area, but make sure it is confined in the larger occlusal area, right? That is the actual occlusal interference. With what you will reduce? You will reduce that with the yellow finishing burr, right? You'll reduce that, and also you'll reduce the red articulating paper marking, so that you will reduce the articulating point. Okay, you have confined that to 12 or 20 microns. You will reduce that also. And also you will reduce a little bit of blue articulating area also, very little. Okay, when I'm checking all this, every point I'm checking the articulating paper marking again and again. I'll reduce the unmarked area. There's yellow marking area, I'll reduce. After this, again, I'll check with the articulating paper. After this, again, I will check with the articulating paper to check the thinner articulating paper marking. And also, again, I will check after I reduce the blue articulating paper marking. Okay, so repeatedly 2 or 3 times, I'm keep on checking to see the static occlusion. I'm getting a proper occlusal marking or not, right? So after this, I will go ahead and finish it with the finishing kit. And after that, I will polish it with the ceramic polish paste. Okay, that ends my static occlusal adjustment. That is for one articulating paper point. Remember, we had 4 articulating paper marking in the posterior and 2 in the anterior. So your ideal goal is to get these 4 marking or these 2 marking in the premolar. If you're not getting, at least you get 2 or 3 articulating paper in the ideal position, that is enough. Okay, so you'll be following this for one articulating paper marking, and you'll be repeating this to all the articulating paper marking in that particular tooth or in the multiple teeth, right? You get this point? So imagine this clinical scenario. Okay, that was about the static occlusion, right? So imagine this clinical situation here. This is the upper molar and the lower molar in the ideal occlusion, right? Centric bite, patient has bite in the centric. You will see ideal occlusal paper marking, right? So that's the MIP contacts. Okay, that's the static maximum intercuspation contact what the patient is having. Imagine this is the crown you have replaced. These are the ideal occlusal points. So when you check the paper after placing the point crown, you check the articulating paper points, you see this kind of articulation. You see these in the mandibular, that is a functional cusp is a buccal. That's right. These occlusal points are fine. Distal marginal ridge also okay. The central fossa is also okay. But you are having occlusal marking in the lingual cusp as well. So these are the occlusal interferences. These are the high points. So you will reduce this so that there is no touching of this cusp to the opposing arch. And how do you reduce these? As I said before, you will check with the 2 articulating papers, and each articulating paper marking you will be reducing, as I said before. Got it? That is in the static occlusion. Okay, these are the points you will reduce. So imagine a clinical situation, the same situation, molar crown, centric bite. You'll keep articulating paper and ask the patient to move the mandible to the right side. Now you are checking the dynamic occlusal points. Okay, you guide the patient, tell the patient to guide the mandible to the right side. You will get occlusal paper point marking on the tooth. Ask the patient to move to the left side from the centric. You will get one more occlusal articulating paper marking. Okay. So after you check on the after you check on the patient's mouth, imagine the patient is having canine guided guidance. Okay, canine guidance the patient is having. So what I said before, after you check the articulating paper points in the posterior for a patient with the canine guidance, you should have markings only on the canine, right? If along with the canine, you are having a marking in this crown starting from the ideal occlusion points, this is the interference you are having. Because in the canine guidance, the posterior should not touch. But here, after giving crown, there is a marking here. So this is the occlusal interference. This is the point where this is the area where you will reduce the crown, right? That's how you identify a occlusal interference, right? So imagine you are giving a crown here and you're asking the patient to move the mandible to the right side. Canine to canine is touching. You make sure no posterior teeth are touching with each other. Okay, only one articulating paper mark, that is a canine, should be there. So now imagine a second scenario where the same situation, but patient is having a group function occlusion. Group function is when the patient is moving the mandible to the right side, along with the canine marking, you will have premolars and molar marking as well, right? So, and those should be the equal markings. So imagine now you are giving a crown here and asking the patient to move on the right side. you will get only 2 markings on this crown. But ideally, in the patient with the group function, you should have marking in all these areas, all the teeth. But you are having only in these 2 areas, these are the occlusal interferences. So you will reduce them, check with articulating paper, ask the patient to move in the right side again. You will repeat this unless you don't get these markings. You will get the markings in all the other areas, right? So you should get equal articulating paper marks in the group function occlusion. That's why we discuss about canine guided and group function. That's why I told you to check the occlusal scheme of the patient before the start of the treatment. Okay, imagine the patient is having canine guidance and you have replaced one crown. Due to the interference, you are having the marking in premolar and in the molar as well. That's not right. Patient definitely will feel not right. Patient definitely will feel the bite issues are there. Okay, so that is the way you check the occlusal marking in the static and in the dynamic position. Okay, once again, in the group function, the crown is there. You should get equal number of markings and equal same intensity is also. Imagine now your intensity of this blue articulating paper here is more and less here. It means that this is the occlusal interference. So you should have equal intensity and all the markings also. That's in the group function. If the patient is having group function, after the crown also, the patient should have group function. Understood? You are feeling like this right now? Confused? So many terminologies and so many things. I know this is, I think you are having this kind of a situation now. I agree, this is not easy, but when you go on practicing in day-to-day basis, and every case you follow this kind of a procedure, this kind of a routine, you will get used to. Okay, just in simple words, I will tell you, if the patient is having canine guidance, there should be no marking in posterior in the lateral movements, right? That is simple. If the patient is having group function, keep all the posteriors in the same what the patient is having, that is existing MIP, or if you are giving a new type of occlusion, all the posteriors should have the markings. Okay, convey the same thing to the lab technician as well. Understood? So always remember, when you check the static occlusion, there should be only dots like these. There should be no lines. But when you check with the lateral occlusion, that is a protrusion or the left and the right lateral occlusion, you should have lines, right? Never lines in the static and never dots in the lateral occlusion, no vice versa. So dots in the static occlusion and lines in the lateral occlusion, that is a dynamic occlusion. So few times you might have seen when you ask the patient to bite open and close, you will see lines in the static occlusion, right? Which are not ideal. So what is this? Why is this happening? It means that the first point of contact is there. Okay, imagine this tooth you have given a crown, or you are checking the pre-occlusion. Ideal occlusal point for this molar is 2 palatal cusps, 1 central fossa, and in the medial marginal ridge. You are having these 2 points here. This is fine, but the drag marks are there. So a patient is biting, when you open and close, patient is biting, and then it is dragging towards the lateral movement. That's why you are having a line here. But lines are not supposed to be in the static occlusion. So why is it happening? It is happening because there is overload of this occlusal area. So you need to reduce this drag marks. These are the occlusal interferences. This is called as a hit and slide kind of a occlusion. Okay. So the condyle, the mandibular is biting. I mean, the mandibular is closing and then the condyle is moving in the posterior or in the lateral to find its proper healthy position. Okay. So this is called as a hit and slide kind of a occlusion. What if you leave this kind of occlusion over a period of time? Okay, occlusal interference. That's what we say, right? When the patient after we give crown, the patient definitely says if he has any issue, I'm not feeling right, doctor, what should do? This is not right. I'm not feeling comfortable. What will you say? We always say this. Oh, crown hai and it will get adjusted with time. Okay, and it's very new to the mouth, and these many days you did not have any of the crown. This is the first crown in your mouth. And we start giving example of new shoes, new clothes, new watch you are wearing. I mean, watch you are wearing, and you feel discomfort. So these kind of example we give and give excuses so that the patient leaves with a positive note. But when you check this kind of implication will be there in the long run. If you want to convert that patient in a full mouth, leave this kind of drag marks and recall him every 6 months. So this one crown, you will convert it into a full mouth rehabilitation case. Yeah, jokes apart. So you're not supposed to do that. That's how, I mean, any of these kind of a mark should be removed. Okay, so what are the implications of this? So you have given a crown, there is a high point. For a period of time, what will mandible do? It will avoid interfering that tooth and trying to bite in other area. So imagine you are driving and you find a pothole. You know that the pothole is there every day. Okay, you'll cross that pothole every day. So what do? You go near and then take a detour and then skip that pothole and go straight, right? The same thing is having. Patient is not able to bite properly in that area. So trying to escape from that, patient will have a deranged occlusion. Over a period of time, there is hit and slide kind of occlusion. That tooth will start moving. Patient will have a mobility. Periodontal breakdown will be there, and over a period of time, the attrition will be there, and there'll be no occlusion. Supra eruptions might be there, and eventually that tooth will be mobile and go for fracture or extraction, right? And what is happening to the muscles here? Muscles are tense, they are strained, they are tender due to the incoordinated muscle function, right? Because as repeatedly there is so much of occlusal interference there, and muscles are getting tensed, and there's stretching of the muscle, right? So that's the implication of occlusal interference. Okay, so you saw what is normal occlusion, kind of a different types of occlusion. You saw how to check the occlusion with the articulating paper, which are the articulating paper marks to keep and to remove in static and in the lateral exclusive movement. And you also saw what will happen if you do not remove the occlusal interferences, right? So next, we will see what causes these occlusal interferences and how to avoid them, right? You remember this slide? We go on this process for any indirect restoration: tooth preparation, impressions, temporization, material selections, occlusal cementation, and occlusal adjustment. Every stage you pass through has to be taken care of. Okay, let's see how it can be done. Imagine this kind of a crown preparation you give to the lab where there are no proper finish lines, no proper inclines, especially if you are having a bridge case. Path of insertion is very important, and amount of reduction of the tooth is not uniform. Sharp angles, pulp exposures, thin enamels here. So this kind of preparation you give to the lab technician, and lab technician will prepare crowns and bridges and give it back to you. You think this will last long? No, right? So crown preparations should be equal. Clearance should be equal in uniform in all the areas, right? And the thickness of tooth reduction should be uniform so that the new crown or a prosthesis which you are giving also has the same thickness, and you are giving a good clearance to the lab technician to work on. Okay, give enough clearance for the material. So what we generally do, we do a crown preparation, make the impression, place the temporary, send the patient, and then write the job order form. As imagine this one, 13436 zirconia crown, 36 ceramic crown, right? But do we keep in mind what material we are using, how much thickness of material is needed to replace that crown, and that much of clearance have I given in the patient? what we generally do, we do preparation and then decide what kind of preparation, what kind of crown we are giving. Based on the one of the criteria also is the financial aspect. Patient does not want to pay more, we will give him PFM crown. But all these should be addressed before, and you decide what kind of restoration, what kind of material the restoration is having. Okay, so you should decide whether the material is monolith material or a multi-layered coping, a multi-layered material. Monolith is nothing but a restoration which is made of a single block, and multi-layered is nothing but a coping and a layer, right? So based on this material selection for the final restoration, you will do a reduction of the crown. Okay, so what are the multi-layered kind of restoration? That is PFM restoration. Porcelain fused to zirconia is a multi-layered. Lithium disilicate with a core and a layer is a multi-layered restoration. And monolith restorations are full metal crowns, full zirconia crowns, monolith zirconia, monolith ceramic crowns or veneers, and feldspathic crowns, right? So these are the monolith and multi-layered. So a multi-layered crown will need more clearance than compared to a monolith crown. Okay, so this is a table where you do a monolith zirconia. Okay, different types of zirconia material. Contact the lab and ask which type of zirconia they are using. Okay, just do not write monolith zirconia crown, lava crown. So lava of which kind? Okay, lava 3Y or 4Y or 5. These are the kind of zirconia types available. If you are work with dent care, it has this kind of a the payment chart they have mentioned: zirconia, zirconia plus, zirconia premium, zirconia aesthetic with extra translucency, right? So all these are different types of zirconia, and these need different thickness to be given, and that clearance you should be given in the preparation. Okay, imagine you prepare a 0.5 or 0.8 millimeter of clearance and tell the lab technician, Mr. Lab Technician, please do a PFM crown. Please do a porcelain fused to zirconia crown. The lab technician does not have enough clearance for him to place a core and then layer it. What he does, he will do something extra. Coping he will place, and then he will place the ceramic, and he will mark the extra clearance to be needed in the opposing. Maybe the lab technician called you, Dr. Saab, see, there is a less clearance, what you do? And we dentists do not take lab technician as a serious one, because after all, he's a lab technician. How can he guide me? Don't worry. You go ahead. I will look after it during the cementation. Don't worry. And just mark the opposing extra. Lab technician का कुछ नहीं जा रहा है. Lab technician will mark the excess from the removing what you have to remove from the upper arch. But you are sacrificing the enamel, or you are sacrificing the tooth, you are sacrificing a crown or a bridge the patient is having in the opposing arch. That's not ethical, right? So first decide what kind of material you are giving, right? And then you decide how much clearance to be given. After that, you inform the lab technician which kind of a restoration has to be done. Only then there will be no occlusal interferences. There will be no high points. The ideal thickness of the material will be there, right? So that's about the giving a clearance for the tooth after the preparation. And you don't want your impressions to be like this, nor like this, right? Torn impressions, voids here, incomplete light body flowing, right? You don't want this kind of impressions to be sent to the lab technician. You might have seen the lab technician pour the cast, send to you and tell you that, doctor, there is no finish line visible, and can you please repeat the impressions for me? We dentists are in too much of ego, and we tell, no, I know what we are doing, and the patient will not come back. You mark the finish line and you go ahead. Lab technician, again, he does not have to lose anything. He will mark his own imaginary finish line and giving you a very beautiful, nice translucency, good polished zirconia layered with ceramic crown to you. Place it with the patient's mouth. and you see there is open margin or there is occlusal interference. That is a high point. When the patient bites, there is a bite issue and the margins are not fitting well, right? But the margins are fitting well in the cast because the cast is prepared by the lab technician. Lab technician will tell you once or twice that the impressions are not good. When repeated, you are not giving a good response to him. He will not get back to you. He'll be just going ahead with his work and he will mark his own finish line and go ahead with the crown or a bridge, right? If your impressions are not good, your cast will be like this. You cannot rectify cast here. You have to make a new impression. At what expense again? Your time. You have to arrange appointments. You have to explain the patient, right? So all these also contribute for the occlusal interferences. Okay. So you remember in the BDS days, we had studied about this finish lines. Why is it important? Usually place the finish lines equigingival or supragingival unless and until it is aesthetically needed, right? Only then you can do a good retraction. And before the procedure of the impression, make sure you do a good hemostasis, control the bleeding. There'll be no fluid contamination there, and the clean area should be there before making the impression, right? When you have giving a good impression to the lab technician, he will be doing a good job. Gingival retraction is also very important. Why you do a gingival retraction? To make sure the finish line is visible. If you are seeing the finish line in the cast like this, ask the lab technician to send the cast after you pour the impression. Okay, you inspect the finish line yourself. If you are seeing this kind of a finish line, आपको दिख रहा है finish line, so it means the lab technician will also be seeing. Okay, and also one point to remember: please use loops for any of your dental procedures. We are working in very minimum area, 0.5, 1 millimeters, and below that also. So having a loops will make your job much easier, right? So give good impressions so that the casts are good. Give a good bite registration, right? Rubber-based bite registration, not a wax bite registration. That's modeling wax is not a bite registration material. You give a modeling wax bite registration, you send the cast with the collection boy from the lab. He roams about whole of the city. Put your work in his two-wheeler, right? And at the end of the day, he goes and delivers all your work there. You know how much of distortion is happening there in the wax. It might melt, it might deform, and during the process, the occlusion might come out, right? So that's the reason use silicone-based bite registration material. And if the bite registration is not good, articulation will not be good. If articulation will not be good, the prosthesis on that will definitely have some amount of occlusal interferences for sure, right? So that also you take care. Then ask the lab technician to use a thicker spacer thickness. Ask what kind of a spacer he is using. You see in this different colored spacer. Tell the lab technician what kind of a restoration you are doing and what kind of a cement you will be using. If you're using a resin modified GIC or a GIC, it needs a thicker space. So the spacer thickness should be more. The spacer is, why the spacer will be applied? That will compensate for the cement thickness. Imagine you are doing a lithium disilicate veneer or a crown. It does not need much cement space. Why? Because you'll be using a resin material, resin composite cement or a light cured veneer cement. So it doesn't need much thickness to be because it is chemically bond. Okay. So if you are giving a crown, PFM or a PFZ, porcelain fused to zirconia, you will be needing a mechanical luting. Okay, you lute the restoration. For that, you should have a good cement thickness. So make sure the cement thickness spacer also will be taken care of. And after all this, you feel that it is not right, always do a core trine. In metal, you'll do a framework or a metal coping trine. Or if you're giving a zirconia coping with a zirconia coping and a layer, make sure you do a trine and check all the margins are fitting properly or not. And also, please communicate with the lab in a proper way. How? Just do not write 3-6 crown zirconia. No. tell him what kind of zirconia, monolith zirconia, layered zirconia, and what kind of a coping you want. Coping should be done in the CAD CAM, or you want to do, if you are doing a lithium disilicate or a metal PFM, coping should be done in lost wax technique, do a wax up and then do this, or you want it to be done in the CAD CAM, right? And what kind of a shade should be used, and any additional instructions, send me the design of STL or of photos. That is, if you are going for a CAD CAM, any zirconia crowns will go through a CAD CAM process, so you can ask for STL or a photos. Okay, so I'll just give an example how my lab technician communication will be, right? This is the real chat. Trying to play the video. Have a good rapport with the lab technician, and mind you, the lab technician will also judge you. If you are not asking more from him, he will categorize you as a general normal dentist who will accept any of kind of his work. If you are not sending the work to the standard lab, right? So these kind of things will happen. So always communicate with the lab technician. Make sure he knows the job. Ask him to send photos. Ask him to send this kind of STL forms, ExoCAD WebView. Although my technician is just, we have a in-house lab technician in our clinic. It's just next door, but still I have a communication. In the morning, even before I start my day, my good morning will be to my lab technician, then my wife. Because lab technician will be sending so many messages saying that doctors have what to do with this and how to do with this, and he has sent these photographs to me. I have to respond back to him saying, do this, keep these kind of occlusion marks, and please send back the design to me. I will check and again send it back. Okay, have a good rapport with the lab technician, because he is the one who is working behind the curtains. You are running the show, but based on his work, your show is dependable, right? Okay, so make sure that if he sends that occlusal markings are this, I will tell him, no, mark like this. These are the occlusal points. Remove these points. I do not want this. This is upper cast, upper crown. So I want a palatal marking. So I'll mark him and make sure that you get these markings, right? So that's how you communicate for each of the cases. And tell the lab technician, make sure he uses a semi-adjustable articulator. Do not use this one-time using articulators, not even a mean value articulator, what we have studied in our BDS, because you know that the intercondylar distance of this mean value articulator and a human skull is not the same. Okay, imagine now you are using this kind of a sectional articulator here. Where is the hinge and where is the hinge in the natural, in our skull? So the radius is not the same from the incisal angle and the condyle in the natural. That's the reason why the opening and closing arc is not the same. That's why when you do a posterior crowns, especially second molar or a bridge, premolars, first molar and second molar, you will always find occlusal interference in the back, because the opening and closing arc is not the same what the lab technician is done. Okay, so always ask the lab technician to use a semi-adjustable articulator. If not, you invest in a semi-adjustable articulator and make sure you keep this in a lab, and you tell the lab technician, please use this for all my cases, right? Okay, so semi-adjustable articulator. So you might ask me, Dr. Saab, you have told me so much about this occlusion, so why can't we keep out of occlusion? That's the safest way to play with. If you do not follow this protocol and reduce entire marking, then you will have this kind of occlusion like this, out of occlusion. What are the consequences you will face over a period of time? Supra-eruption will happen, and supra-erupted tooth will not be in the ideal occlusal form. Again, over a period of time, the patient will come back to you with any of the occlusal interferences and bite issues or migrations, or patient is having a jaw pain or a headache or kind of a shoulder ache if it is going in the long run, right? So we're all in the digital era now. Okay, so the present and the future of dentistry is digital. Please embrace this digital workflow. Just to quickly tell you about how it goes, because this makes our job much easier, right? Patient comes to you, you will scan, and or you'll make an impression, send it to the lab scanner. Lab will scan your cast, and then it will be milled or it will be 3D printed, and then the processes will be delivered. Okay, in this every step, you can be much precise of what you are doing, right? Here, here what is happening? Here what is happening? Intraoral scan is being taken, right? Intraoral scan is being taken for a molar. The lab technician will mark the finish lines, design a crown. This is a monolith crown which is being designed. How fantastic is that, that you learn this kind of designing, ExoCAD, and then sitting with the lab technician and explaining, do like this and do like this, right? So learn the newer art now, develop a new skills, learn the ExoCAD for crown and bridge at least. If you're planning implants, then implant ExoPlan is there. Make sure you learn all these new techniques. Only then you will can guide the lab technician. You can guide the lab technician, and then you can tell him what is to be done and what wrong is he doing, and you can correct it. Okay. If you're doing a CAD CAM restorations, this is again a real chat of my communication with the lab technician. You can use a virtual articulator and set the condylar angles in the lab tech, because lab technician does not know the condylar importance of condylar angles, right? So I tell him that, Mr. Lab technician, please keep this angle at this level, and then check the lateral movements and check if any interferences are there, protrusion, all the teeth are touching in a very ideal manner, get a good anterior guidance, keep the Bennett angle, immediate shift. All these things I manage with the lab technician, and I know how to use ExoCAD. That's the reason I tell him, Mr. Lab technician, you do like this. Okay, so almost like 2 years now, 2.5 years, I'm completely into the digital dentistry. I've been scanning. I'm using Omnicam, Itero for the scan. Lab has in-lab Serac in-lab and Programmil from IOCLAR. So I communicate with him, sit with him, and I tell him, remove this, keep this new point, change the shape of the crown, change the shape of the bridge, connector space should be this much. So when you do this digital dentistry, all the errors which could be there by using the analog one will be reduced, and you'll be keeping a check on, and you'll have a precise numbering where you can have a good outcome also. Okay, embrace the digital dentistry as much as quick as possible. Okay, so after doing this again, if you want to check the occlusion digitally, this is the device. This is occlusense from Bausch company. T-Scan is other company which has this digital occlusion. This will give you a very precise occlusal markings on each cusp, each incline, each fossa, each ridge of the tooth. Okay. Also, advantage of this is that it can be recorded, kept in the record as a patient record, and also the occlusal paper marking can also be replicated in the patient's mouth, right? So that is how you check the occlusal interferences in the patient's mouth digitally. So that's not it. After you do a cementation, you check the occlusal marking, reduce and get an ideal occlusal marking on the patient, and then you take a bite wing or a PA radiograph. Why? To check the proper fit of the restoration. You see this? This is a proper fit. This is not a proper fit. Okay, I'll show you with the marker here. This is the proper fit. This is a proper fit of the ceramic crown. This is not a proper fit. This is not a proper fit. This is not a proper fit because there is overhanging. This is definitely open margin. This has a open margin. This is not a proper fit. When this kind of a fit is there, definitely the occlusal disturbances will be there, because on the cast the crown is sitting properly, but on the patient, in the patient, it is not sitting. So it means that here there is some amount of discrepancy which is seen, right? So make sure during the trying phase, before you cement, do a trying, take a radiograph, by doing radiograph, and then check all these points. Okay. So in this course of webinar here now, you have learned why to check occlusal points, when to check, and how to check the occlusal points. So for me to conclude, take home messages: know the basics of occlusion, know the terminologies, know how the normal occlusion works, follow each step meticulously during crown and bridge cases, make accurate impressions, retraction, bite registrations, communicate with the lab. This is most critical point. Communicate with the lab, visit the lab, sit with him, tell him your perspective of getting a good restoration. What will happen if he keeps one extra occlusal point? How does it affect the patient, right? Recheck the work sent by the lab. If it's not good, resend it to the lab and get the proper work done. Use good articulating papers, incorporate digital dentistry, right? So for me, there are 3 golden rules for occlusion, whether it's adjusting the bite or restoring a full mouth rehabilitation cases. So I follow this one: always equal contact on all the teeth. Okay, that is when it is in CR, centric relation. And when you get in the post anterior, get the mandible in the anterior, posterior disocclusion should be there. Okay, that's a Christensen phenomenon which we have solved. That's a, unless you give a group function kind of occlusion in the posterior. Anterior, when you get anterior edge to edge bite, posterior disocclusion should be there. And a free and up in an obstructed envelope of motion. When the patient is chewing, patient should not feel any interferences. Patient should not tell me that, Doctor Saab, after you have given the crown or a bridge, my chewing, way of chewing is different. Unless it is full mouth case, but again, you have to train him with the in the temporary phase as well, right? So this is the take home message. And only thing what you can do is practice, practice, and practice, right? Direction is not important, is more important than speed, right? So many are going fast, but in the wrong direction. That will not help you. Just because the lab has sent you a work, you don't need to fit it on the same appointment. Make sure you convince the patient, you tell him that you will be checking the restoration. If it is not good, I'm not going to cement it. And do not commit. I do not commit, even till now, I do not commit that this will be your last appointment. Do not use the word last appointment. When you use this, patient mindset will be the same. Tell him you will get the work if you are happy, and more importantly, I am happy with the work, only then I will be cementing permanently. If not, give me one more appointment and I will send it to lab, get a perfect work for you. Do not compromise. Okay, if there are high points, send back. Do a BISC trial before the final. You do a core trial to see the margins are right. Mind you, even the lab technicians are judging you. They're categorizing the dentist. I do not want to name the lab. When I visited the lab, there are trained lab technician for one particular kind of a dentist, premium dentist. Okay, one other regular normal lab technicians who do not, who work only on the dentists who do not care much about the work. They want the work in just 2 days. Those are sitting separately, and the person and the dentist who are having a premium work are sitting separately. So the lab technicians and the labs are judging you. Tell them that you are a premium dentist and I want a premium work for you because you are paying a good amount of money. Choose a good lab, more than the lab, choose a good lab technician. Once a lab technician is used to, ask the lab to send all your works to him. Okay, so you can request him, please lab, send my works to him. I'm comfortable with him. Okay, so that's how you work on your cases and build your own road to success. And it's not the destination, it's the journey that matters, right? So this is just the basics of what I can speak about occlusal interferences. clinical implications of it, I have spoken as much as possible, which can be covered in my given time. I think I have over spoken. Pardon me for that. Yeah, definitely it is a vast subject. Occlusion is a vast subject, and again, high points and occlusal interferences is a part of occlusion. So hopefully I have made little bit difference in your thinking, and hopefully, inshallah, you will be incorporating this in your practice very early. Okay, so if at all you get a call from any of the patient today night at 11:30, do not worry, sleep happily, because you have learned a little more extra about managing occlusal interferences. Okay, thank you so much for your time and
Thank you.
patience listening. And it was nice speaking on this global dental professional platform. Thank you so much.
Thank you very much, sir. What a wonderful presentation. Way back in 2013, I would have got a gold medal in my fourth paper. That final
Yes,
paper, 75 marks. Occlusal,
yes,
selective grinding is a 75
selective
marks paper
grinding.
for a
Yes,
post, yeah,
yeah,
for
that was
postgraduate.
a main question. Main question now.
Main question, yes, yes. And so many,
Yes.
as a moderator, I was feeling, what should I ask? Everything is been covered. कुछ बचा ही नहीं छोड़ा Sufiyan साहब ने हमारे लिए. Anyways, but I had still one question for you. So, quickly before we wrap it up for the day. So most of our occlusal corrections and selective grinding is done on a pre-cementation appointment at
Yes,
the level of
yes,
BIS. If it is done at the BIS trial, we don't have to worry because it's go back
yes.
for reglazing. But if we,
Reglazing.
what is, can you share some light on that pre-cementation selective grinding versus post-cementation selective grinding? Do we see a change? Because we are whatever
Yes,
whatever we are doing is at a micronic level, and there would be
yes,
changes if would be there.
yes, yes. It's a good question, and it's a good thought-provoking. Definitely, before cementation and after cementation, you will have a little bit of differences for sure. What I usually use is a trine cement. Okay, every resin cement or a veneer cement will have a trine cement, which will not cure, but it will compensate for the thickness of the cement which you are using in the final stage. So use that during the cementation, pre-cementation, use that and then check the occlusal marking. Okay, as Dr. Saab was saying, there will be a change for sure. What I have seen in the changes is the pre-cementation, if you're having occlusal, just listen to this carefully. If pre-cementation, if you're having occlusal interferences at one point, imagine, on the cusp, okay, and after the cementation, you will check the same occlusal point, it would have been moved little mesial in the maxillary, and it will be moved towards a little distal in the mandibular. Okay, so when you are doing a selective grinding or a occlusal check or occlusal grinding pre-cementation, keep this in mind. After you grind now and after you cement it in the maxillary, this occlusal point will move mesial. In the maxillary, this occlusal point will move in the distal in the mandibular. So if you feel that this occlusal point after cementation is fine in this area of the cusp or little more mesial, do not touch it. Okay, if the patient is comfortable, if you are having a good intensity of the occlusal paper marking, do not touch it, right? If after, because after, before, definitely after the cementation, the crown seating will be much better and this marking will be much more comfortable for the patient. But if pre-cementation, patient is not comfortable and you are seeing the very dark markings compared to the adjacent teeth, then definitely you have to do a selective grinding or occlusal correction, send back to the lab for reglazing, or and also if you're using a zirconia, repolishing. Okay, do not, chair side can be done, but that's not the ideal way to be. Small points can be overlooked and then you can go ahead with the cementation. But if you have a 2 or 3 markings or a bridge the whole of the bridge has this kind of occlusion interferences, then definitely send back to the lab and reschedule the patient again. Yeah, Dr. Shahul,
Sir,
I think you
yeah,
can also add up to this if you have anything so.
sir, आपने मेरे लिए कुछ छोड़ा ही नहीं है, sir. You have been just on the spot. I think it's. I have no question, nothing to add on to whatever you're saying. It's spot on. Just I had one
Yes.
important doubt, for personal doubt, as I'm not really into digital dentistry, but I had this personal doubt that see, we scan our prepared tooth, we scan the opposite, and for bite, we scan maximum intercuspation probably on the opposite end. But
Yes.
nowhere we talk about dynamic occlusion here. We are talking
Yes.
about static occlusion in our scans.
Correct.
You said when we are articulating, we should not not take sectional impressions and not, but look forward for adjusting on a semi-adjustable articulator. So when
Yes.
we are doing for the single crown and bridges for our intraoral scanners, and we are recording about dynamic occlusion, we have to check it in the patient's mouth.
Yeah. See, what I generally do, that's what I said. Even though we are into digital dentistry, pre-occlusion photograph is our blueprint. You do either in the analog or in the digital, your pre-occlusion photograph should be the same as the post one. So even though I scan it and send it to the lab technician, in the exocad, there are lateral movements which can be adjusted. So according to that adjustment, I will tell the lab technician and I will send this photograph to him. I'll make sure these occlusal points are the same as what occlusal points the lab technician is having after the articulation. So by doing this, I'm having a recheck where ideal occlusal points and also what the patient's maximum intercuspation is there. So even after this, if I have any of the doubts, then I will get a 3D printed bridge before the final one, or a 3D printed that will take around 30 minutes of the printing. Since I'm having a in-house lab here, so that will make the things easier. I will get 3D printed PMMA crown, recall the patient for one quick visit, take out the temporary, place this, and check the occlusion. And I will not change this. I'll send the patient along with this kind of a PMMA crown or a bridge, and tell the lab technician any selective grinding to be done, I will do on that. And again, I will tell the lab technician to do the same changes in the design as well.
Yeah, thank you so much, sir. Shortage of time, but
I
so
know
much to
you are
learn
at the
from you.
airport. I
So
think.
much of learn
What
from
time
you.
is your flight?
We are already boarding.
Oh, okay,
But I
fine then.
had
Have a
so
nice
many
trip.
things, but we would definitely connect personally, and I would request
Yes,
all the participants to connect personally with you through your Instagram and thing, and solve their
yes,
questions. What my take-home message is that if you're going to perform procedures, as my own guru says, if you're going to perform all these procedures, what you showed up in terms of maintaining occlusion, maintaining proper lab communication, and making sure your impressions are perfect, the final product which we deliver, irrespective of the cost factor or time factor taken to deliver that particular product, when you see that same thing after 15 years, that
yes,
particular product will stand out in that particular mouth as an undisturbed, perfect
yes,
prosthesis, unlike any other process would have probably deteriorated over a bit of time. The
yes,
difference between long-standing perfect prosthesis for versus something which is just for a couple of years is this particular protocol which you should follow. I truly
yes,
believe that that protocol should be followed as written on stone.
yes,
And there's nothing about being a prosthodontist about it. It's like a general
yeah,
dentist itself should be doing that.
yes,
Margins, contact points, occlusion, and then you see your patients, how your practice grows.
yes,
Initially, it may take a
exactly.
couple of, as you said, practice, practice, practice. It may take a couple of more
Yes,
appointments to retrieve it.
yes,
But if you and your lab technician are at one synchronized at one particular level,
correct.
I think then these number of appointments will cut short because they know exactly
Yes,
what you want and they're able to handle it. That's been
yes,
my
exactly.
15 years, which has told me I've made mistakes and I've
Yes,
taken shortcuts and I've repented it.
yes,
And now I don't take.
yes,
Yes, for me, I'm definitely going to concentrate more on occlusion, which we sometimes tend to
yes,
neglect. I too.
It needs
Thank you
more
so
of
much, sir.
patience also. Yeah.
Yeah, yeah.
Yes. Yeah, we
Okay,
don't
sir.
want you to miss the flight.
Yeah. Thank you so
Yes.
much, sir. It's been a pleasure, Miss
Same
Hameed.
here.
Inshallah, when you come down to Bangalore, we would definitely meet up, sir, and look forward for some sort of joint ventures.
Yes,
Thank you
yes,
very
sure.
much, sir.
Sure. Thank you. Thank you once again
Okay.
for this opportunity, GDP.
Okay. Thank you. Allah
Yeah.
Hafiz.
Bye bye. Bye bye. Salam.
Allah Hafiz. Uh, okay. I think we can all exit from the system.